Hello, everyone, and welcome to another episode of PEEPs. Today, we're excited to bring you another in our series of rapid-fire journal clubs. We're going to be discussing the INPULSIS 1 and INPULSIS 2 trials of Nintedanib and an antifibrotic drug in ILD. I'm also excited today because we're two great guests that we have joining us. First, we're being joined again by a familiar voice, Robert Wharton, who most recently helped us think through the STELLAR trial in PH. At that time, he was an internal medicine resident at Mount Sinai in New York, and now he's a first-year pulmonary and critical care fellow at Johns Hopkins. Robert, welcome back, and I hope fellowship's off to a great start.
Hey, yeah, thanks, Luke. Sure is. I've been using your summer series a lot to great effect in the MICU. And I'm very excited to be here today. I'm excited to be giving the world of ILD some love on the Rapid Fire Journal Club series. And I'm even more excited to introduce our guest, Dr. Nicole Ng, who's the Associate Director of the Interstitial Lung Disease Program for the Mount Sinai National Jewish Health Respiratory Institute, and someone I worked with and learned a lot from as a resident at Mount Sinai. Welcome to the podcast, Dr. Ng.
Thank you, Robert and Luke. It's great to reconnect with you again, Robert. It's a privilege to be on the podcast with both of you today.
Yeah, excited to have you on. Thanks for joining. And so, Robert, we're talking about the INPULSIS 1 and 2 trials. And maybe before we get into the meat of the paper, could you give us kind of the background information we need to know before we get into it? Kind of what was the context this was released into?
Yeah, what's interesting to me is this paper came out in 2014. And at that time, in terms of pharmacologic therapy for ILD, there was a laundry list of things that didn't work. Imatinib had been studied and had no effect compared with placebo. Empiric treatment for GERD had been tried. That didn't work. Warfarin caused more mortality and bleeding. And probably most famously, there was a trial called Panther IPF, which combined prednisone, N-acetylcysteine, azathioprine, and surprisingly showed an increased mortality in the treatment group. Empiric antibiotics didn't work. Endothelin antagonists didn't work. PDE5 inhibitors in patients without pulmonary hypertension didn't work. So, long list of disappointing trials. Dr. Ng, is there anything about the background going into this that you think is important to highlight?
I agree. And I think it was very important that you discussed the clinical arena up until this point, where it's been pretty disappointing and discouraging. And these trials were published in 2014. And as you highlighted, there's been numerous clinical trials that had been done in IPF. And not only did they not work, some of these treatments even caused harm, as you mentioned in the Panther trial. So at that time, prednisone, NAC, azathioprine, that was the standard of care. If you looked at the guidelines back then, it was something to be considered that was based on expert opinion and what was thought to be the pathophysiology behind IPF at the time. So it was really a surprise when they finally studied it in a randomized controlled trial setting that it was actually associated with increased mortality. The management of IPF was discouraging with a 3 to 5 year survival. That's worse than many cancers and with no effective treatments. And management really was limited to lung transplant, which was also fraught with issues, or just palliation. And so these trials really altered, as we'll see, the therapeutic landscape of not just IPF, but many of the ILDs as well.
Yeah, thank you for that. It sounds like overall this was a frustrating space at the time with not a ton of successful therapies. And so that's a good frame of mind as we get into the meats of this. Robert, I feel like we have a good kind of baseline understanding. Do you want to tell us a little bit more about what they did? Kind of what was the design of the paper?
Yeah, so Nintedanib, briefly, is a receptor blocker for multiple tyrosine kinases that mediate elaboration of fibrogenic growth factors such as platelet-derived growth factor, vascular endothelial growth factor. It was originally tested as an anti-cancer drug. They studied it in two parallel randomized controlled trials named INPULSIS 1 and INPULSIS 2. These were double-blind, placebo-controlled trials in 205 sites in 24 countries in the Americas, Europe, Asia, and Australia. And there was a twofer. They were published in the same publication in NEJM in 2014. They included people who were greater than 40 years of age, diagnosed with IPF within the previous 5 years, so excluding people in whom the damage was already done, with an FVC 50% or more predicted, DLCO 30 to 79%, and they also had central review to make sure that the patients did indeed have IPF. Dr. Ng, maybe you could comment on why they chose to exclude younger patients and those who had a longer period of disease activity.
So let's go over the inclusion criteria. So at that point, this is pretty standard and consistent with the ATS and ERS guidelines at the time, which was published in 2000. IPF is generally considered a disease of older adults, so usually around the sixth to seventh decade of life. So it wasn't so much they're excluding younger patients, it's just that it's just that patients who are under the age of 40 are not likely to have IPF. Instead, they probably have a more familial or genetic form or a connective tissue disease associated ILD. So this cutoff helps more to ensure that the population is selective for IPF. And also the exclusion criteria of patients who are diagnosed beyond 5 years also makes sense in that, firstly, you said the median survival is about 3 to 5 years. So if you're enrolling patients close to that 5 year mark, it doesn't make sense because you don't want to enroll patients who don't survive beyond the trial duration. This was for a year. And as you mentioned, they would be too sick to qualify. And on the flip side, if you have someone who is really diagnosed with quote unquote IPF for 10 years, I would really question that diagnosis of IPS and wouldn't include them either.
Great. Thanks for clarifying that. A couple of other inclusion criteria to highlight. So they were allowed to be on some prednisone, up to 15 milligrams, if the dose had been stable prior to screening. But other therapies for IPF were not allowed, including high-dose prednisone, azathioprine, N-acetylcysteine, and other investigational treatments. I also want to highlight the CT and lung biopsy criteria because getting the diagnosis right is really hard and critically important in IPF. So they said that without biopsy, they must have absence of atypical features and either honeycombing or reticular abnormality and traction bronchiectasis. And they had disagreements between pathology and radiology resolved by discussion between the radiologist and the pathologist, and pretty standard histopathologic criteria for IPF diagnosis. Anything you wanted to highlight about their diagnosis protocol?
Yeah, absolutely. So similar at the time, this was the standard for the diagnosis. And in fact, the gold standard for the diagnosis of IPF used to be a surgical lung biopsy, and you're looking for a definite or probable UIP pattern. But as you imagine, as you mentioned, it's not always feasible. So similarly, radiographic, definite or probable UIP was also acceptable. But this distinction is not always easy to make. Oftentimes, even in our MDDs now, the pattern's not clear, and we're thinking, is this UIP, HP, fibrotic NSIP? And additional clinical information is really critical to come to the diagnosis. They didn't mention it directly here, but in the supplement, it was mentioned. And the onus really for this clinical trials is on the provider screening to make sure there's nothing else in the history, exposures, labs, or anything else that's suggestive of a secondary etiology to make sure they truly have IPF.
Awesome. So it sounds like they did a really rigorous job of trying to make sure that they were truly enrolling the patient population we were interested in, these IPF patients. And I always appreciate in a paper when there's explicit criteria that they're using and they communicate that transparently for something as tricky or as nuanced as an ILD definition. So I think that's a real pro here too. All right. So we've talked a little bit about who they were aiming to enroll, what their inclusion and some of their exclusion criteria were. Robert, do you want to help us understand who actually was in the trial? What did the actual population look like?
Yeah, so to go through their table one, 80% of the enrollees were male. The median age was 66. Between 60 and 70% of them were former smokers. And the average time since diagnosis was 1.6, 1.7 years. Their mean FVC was 80% predicted, which is pretty preserved. And the DLCOs were in the 40s, which is a moderate gas transfer defect. All satted well on room air, and going off of the St. George's Respiratory questionnaire, they had a moderate impairment in their ADLs and functional status. In summary, this was a group of older male patients with centrally adjudicated IPF by imaging and or biopsy, with normal FVC and resting oxygen saturation, but with moderate gas transfer defects and symptoms.
Perfect. I always like when I'm reading a paper like this to try to put that into the newspaper headline version of who was actually in the trial. It helps it stick for me. Okay, so now that we have an idea of who was actually in the study, Robert, walk us through what they did and what they found.
Sure. So the primary endpoint in the study was the annualized rate of FVC decline, which they analyzed with a regression model with sex, age, and height as covariates. They randomized patients 3-2 to receive either nintedanib or placebo and tracked their spirometry at 2, 4, 6, 12, 24, 36, and 52 weeks. They did allow patients to interrupt receiving the dose because of adverse events, and they could reinstate at the lower dose. Dr. Eng, we talked on our episode about sotatercept how the 6-minute walk test in pulmonary hypertension got to be the standard surrogate endpoint. Here we have another surrogate endpoint that's common in the field, and it's not mortality and it's not hospitalizations. So, what should we know about FVC decline as an endpoint in ILD trials?
Yes. That's an excellent question. I think it's actually very important to spend some time discussing endpoints in clinical trials because defining the right outcome is crucial to the success of the trial. Outcomes, or they're also called clinically meaningful endpoints, is from the perspective of the patient and should generally measure one of three things. One, symptoms, so how the patient feels. Two, function, their ability to perform activities of daily living. Or three, survival. This endpoint has to be well defined, reliable, measurable, interpretable, and sensitive to the effects of the intervention. So, the ideal clinically meaningful endpoint in IPF would be mortality and or hospitalizations. But as you can imagine, it's going to be very impractical to conduct a study of such large sample size and follow up that it becomes prohibitive to use this endpoint. We also don't have very well validated measures for symptoms or functional status because it's difficult to measure and also very subjective. And so we use surrogate endpoints, which is an indirect measure that is intended to substitute for a clinically meaningful endpoint. But these must be validated. The forced vital capacity, it's imperfect, but it is the most commonly used physiologic measure in clinical trials for IPF. But it's also important to understand the caveats with the FVC. So, for example, reduced FVC is suggestive of restriction, which is more accurately measured with the total lung capacity, but also similarly for practical reasons, spirometry is just more easily attainable. FVC can also be influenced by external restriction, neuromuscular weakness, air trapping, to name a few. But despite these issues, FVC has been shown to correlate with survival. So a decline of 5 to 10% over 24 weeks has been associated with a twofold increased risk of death. Greater than 10% decline has been associated with a fivefold increased risk of death. And so the minimal clinically important difference is thought to be around 2 to 6% decline. And that's how I got to using FVC as a primary endpoint in not just this study, but most studies in IPF and ILD going forward as well.
That's really helpful. To me, that helps reframe the way I was thinking about it. I think it makes me more confident about FVC decline as a surrogate endpoint, so it indirectly may matter to patients. Luke, did you have any thoughts about this versus full PFTs?
Yeah, I think this always is. I'm always curious if only lung volumes were more easier to measure. I'm always curious what some of these studies would show if and the research in general would show if we were able to truly measure lung volumes as a more direct measure of restriction, which is essentially, I think, what we're trying to get at when we use FVC. But I absolutely appreciate the practical concerns in using something that's able to be done and that hopefully also is pretty significantly correlated with mortality. It sounds like it's a good surrogate outcome. Okay, so we've talked a little bit about their primary outcome and kind of the overall structure of the trial. Robert, were there any kind of key secondary endpoints we should be paying attention to?
Yeah, so just to round out the methods, some of the secondary endpoints included the time to the first acute exacerbation and the change in the St. George's Respiratory questionnaire. They defined acute exacerbations as meeting all of the following criteria, being unexplained worsening or development of dyspnea within the previous 30 days, new diffuse pulmonary infiltrates visualized on chest radiography, high-res CT or both, or the development of parenchymal abnormalities with no pneumothorax or pleural effusion since the preceding visit, and exclusion of any known causes of acute worsening, including infection, left heart failure, pulmonary embolism, any other cause of acute lung injury, which seems a little hard to adjudicate, but at least they had a upfront protocol for doing it. Dr. Ain, do you have any more comments about the methods?
Yeah, so the secondary endpoints make sense, and actually in the prior phase 2 trial of Nintedanib leading to INPULSIS, there was a statistically significant decline in acute exacerbations with Nintedanib in a dose-dependent manner. The incidence was actually 2.4 in the placebo arm and 15.7 on the highest dose. And it was very exciting. And I think everyone is very excited to see what was going to come out of this trial. I would add, I've been interested to look at some additional parameters like a 6-minute walk test, but that's easy for me to say.
I know I'm always greedy. I feel like I always want more. But again, very easy for me to say, having never conducted a trial. All right, so great. That was a nice overview of the methods and the outcomes we're interested in. Robert, what did they find?
Yeah, these were positive trials. In both INPULSIS 1 and 2, there was less FVC decline in the Nintedanib group than placebo. Everyone's FVC declined some. In the treatment groups, this was about 113 milliliters, whereas the placebo groups declined by about 200 to 240 milliliters. The FVC curves start to separate on the Kaplan-Meier plot at about 6 to 12 weeks out, and they stay separated. They did a few sensitivity analyses of different time points of FVC decline, which were consistent with the primary, and they all suggested that no matter how you sliced it, Nintedanib was superior to placebo. One thing I will highlight is that they expected a certain amount of missing data because in the phase 2 trials, they knew that these drugs cause significant adverse effects. And while there was about the same rate of discontinuation in the placebo as the treatment arms, there was less data collected in the folks who discontinued the study drug than the placebo, which could create a bias towards a positive effect, given that those people are not prognostically the same. However, some of their sensitivity analyses involved correcting for the people who had dropped out of the trial with some multiple imputations. That strengthens my confidence that this is a real result. Looking at exacerbations, in INPULSIS 1, there is no difference in the time to the first acute exacerbation, but there was in INPULSIS 2. There, the hazard ratio was 0.38 with a confidence interval spanning from 0.19 to 0.77. And they had a pre-specified pooled sensitivity analysis, which did show an overall benefit for exacerbations. And for quality of life, there was a clinically insignificant difference in INPULSIS 2, and there was no significant difference in INPULSIS 1. These were not significant when pooled. The authors write that these differences were not explained by differences in baseline characteristics, so I read this as probably a statistical fluke. Importantly, there were no differences in death from any cause or respiratory death, and the adverse effects, which I think everyone was waiting for, are this terrible GI side effect profile. 2/3 of the participants had diarrhea, quarter had nausea, and 10 to 12% had vomiting. 8.4% of participants discontinued due to GI side effects. There were also a little bit of liver enzyme elevations, 5%, and rare cardiovascular events. So 5 patients with MI in the treatment group and 1 in the placebo group in both trials. Dr. Ng, I wanted to ask if these adverse events have been borne out in post-marketing studies. Are we seeing this in practice? Beyond the GI side effects, which I'm sure everyone sees, but what about the rates of myocardial infarction and liver enzyme issues?
Great, thank you. I think that's a great summary of the secondary endpoints and the outcomes. It was very surprising that with the acute exacerbations, I think we were really expecting something positive there, but it's quite a little bit of a bummer that nothing panned out of that. And similarly for the St. George's Respiratory Questionnaire. With regard to the side effects, so starting with the GI side effects, the high discontinuation rate is certainly concerning, but post-marketing studies have actually shown that patients tolerate it better in the real-world setting than in clinical trials. I think part of that is we're learning more about these drugs, and then now we're counseling more. I always tell my patients there are many ways that we can mitigate the severity of these side effects, making sure they're taking it with a full meal, that they're taking it 12 hours apart. We can do a slower up titration of the medication. We can also lower the dose, and we can add loperamide as needed. And with all of these measures, I would say most of my patients are ultimately able to tolerate it. Regarding the myocardial infarctions, so there's a subsequent trial, which I'm sure many of you are familiar with, the INBUILD trial. So in that, they actually didn't find a difference in the incidence of major adverse cardiovascular events or myocardial infarctions. There are post-marketing studies that have reported rare occurrences of it's definitely something I'm mindful of. So I will avoid nintedanib in patients with significant uncontrolled cardiovascular disease, particularly in IPF, where we have pirfenidone as an option as well.
Awesome. Thank you, Dr. Ng. I appreciate those nuances too about how you're counseling your patients on some of these medicines to maybe try to mitigate some of the side effect profile. Because overall, these results are maybe not screamingly the way we may have wanted in some ways, but also there is some benefit to these drugs. And so trying to think about ways we can ensure folks are able to take them if we feel like it's indicated for that patient is important. We've talked a little bit about earlier in the methods about their central review of diagnoses and some of the kind of rigorous things they were doing in their trial design that make us more confident in these results. But with every paper, there's always some limitations. Robert, are there any things that you want to make sure we mention that to keep in mind as we're trying to interpret and apply some of this to our patients?
Yeah, one concern I mentioned before is that of differential dropout, which I think is addressed by their sensitivity analyses. The second is that I just wanted to highlight that the data were analyzed by the study sponsor, and I wanted to pull the room about that because we don't always see that in the trials we've reviewed here. How do you think that affected the results, if at all?
So, data analysis by sponsors is not that unusual, especially for a trial of this size. In fact, I would say most industry sponsored trials, probably there's been some literature on this, but a little over 50% are actually analyzed by the sponsor or the contract research organization. So, beyond the data analysis, what I think is even more important is to note who drafted the manuscript. And in this case, it was the investigators.
Yeah, I think that's if I'm being a really strict purist, would I like it if they had nothing to do with the trial? Of course, but it seems like this is not too outside the standard here. And then I agree, totally agree, Dr. Ng, if as long as they're not, involved in drafting the manuscript and the outcomes and discussion sections, I feel more confident or less worried about their involvement in the data analysis.
Yeah, I think there are also some interesting points to be made about the external validity of this trial and which extrapolations are we allowed to make. There wasn't directly reported a mortality benefit over the trial period, but we have some more post-marketing data now. Do we think that treatment with nintedanib reduces mortality at this point? There was a signal for a decrease in acute exacerbations in this pre-specified sensitivity analysis pooling the two trials. Are we counseling patients that nintedanib reduces acute exacerbations? And finally, there are questions about expanding the indications. What is its role in earlier disease? What is its role in other forms of ILD or in advanced disease? Dr. Ng, what are your thoughts about the broader context of this trial?
Yeah, absolutely. I think that's a great question for us to understand. We have this great trial. How does it apply to our patient? So, firstly, as you mentioned, this trial was not designed to answer the question of mortality. The evidence for this lies mostly in a mixture of post-marketing data, observational studies, and/or meta-analyses. There have been a number of articles on this. There are some that show that there's no difference in mortality, but I would say overall, most studies will point to a mortality benefit or at least a trend towards benefit. The data for reducing acute exacerbations is a little more limited, at least most of the INPULSIS tomorrow trial. When that's pulled together, it favors nintedanib. Interestingly, in Japan, they're actually using nintedanib in the acute management of acute exacerbations in the hospital setting and found that improved outcomes. More to come on this as these were small retrospective studies. But I would say in my patients, if I do counsel them about this, I would add that it may reduce exacerbations in addition to all the other benefits as well. We do know that even in less selected patients, nintedanib does slow FVC decline, as described in the INVIL trial that looks into patients with non-IPF progressive pulmonary fibrosis. Despite the heterogeneity of ILDs, there appears to be a final common pathway underlying disease progression that can be slowed with nintedanib. And I also do think that nintedanib works in patients with more advanced disease. As we mentioned, In our trial here, patients have milder disease. They were diagnosed about a year and a half in, and they had preserved FVCs. But in the INBUILD trial, they had notably a different subset of patients, but the patients were actually sicker. Their FVC was about 68% and still showed treatment benefits. It's promising to me.
Awesome. Thank you so much, Dr. Ng. I feel like that's a really helpful overview of how these fit into your practice and applying them to some different populations that maybe this paper in particular wasn't explicitly designed to answer. And we have mentioned this growing role for antifibrotics in IPF. There is another antifibrotic to choose between. Robert, do you want to just quickly tell us about it and how it may or may not differ between Nintedanib?
Yeah, pirfenidone is the other antifibrotic. It inhibits TGF-beta stimulated collagen synthesis and blocks fibroblast proliferation in vitro. The side effect profile may have less diarrhea, but 30% of patients had a rash, and there are some reports of DRESS and SJS. The differences in FVC decline in the trial, which was called Ascend, 23% had no FVC decline in the treatment group and 10% in the placebo group. And similar to the Nintedanib trial in INPULSIS, more advanced disease was excluded, although in general, the patients in Ascend were sicker. Dr. Ng, how do you think about choosing between one drug and the other?
That's a very good question. It's very difficult to compare these two studies, even though they're similar, but it's difficult to study that to separate them because they actually have slightly different inclusion and exclusion criteria. And as you mentioned, the baseline characteristics were a little different. Patients in the Ascend trial, they capped their FVC at 90%. So that's why their FVCs tend to be a little lower. So approximately 68%, which is about 300 to 500 cc's lower than in the INPULSIS trials. However, the way I look at it is both antifibrotics were associated with a similar relative reduction in FVC decline. It's about 45% compared to placebo. I don't know if that's the most statistically sound way to analyze it, but that's how I try to compare the two trials. In my patients with IPF, my decision for which antifibrotic to prescribe is guided more by their adverse event profile. And I generally employ a more shared decision making with the patient. Like you mentioned, I actually have a patient who's a farmer. And so pirfenidone was not an option because of the sun exposure risk. And so we ended up going with nintedanib, or vice versa. I have some patients who travel a lot and they said they couldn't bear to be on a plane with the GI side effects. So we opted more for the pirfenidone. So I would say overall, it's an individualized discussion for patients with IPF.
Yeah, that is certainly taking into account what our patients' day to day looks like is part of what's fun, I think, about pulmonary is some of the kind of nuanced things we get to do and the conversations we get to have with our patients that we see in clinic. All right. So that I think has been a really great discussion of this paper. Circling back around, Robert, if you were going to give us kind of your takeaway when you're looking at these trials, what is it that's your take home message?
What I take away from INPULSIS 1 and 2 is that in patients with moderate IPF, nintedanib reduces the rate of FVC decline, probably reduces exacerbations, and may improve mortality, but does not improve quality of life.
Awesome. Yeah, I think that's a really nice high level review here of the conversation we've had today. And we've talked a little bit about some of the outstanding questions. I think just before we end the episode today, Dr. Ng, I'm curious, as someone who does this clinically day in and day out and is clearly really well versed in this literature, I'm curious what your thoughts are on future directions in IPF and with antifibrotics.
Absolutely. So the antifibrotic trials really changed therapeutic landscape in the management of ILDs, but it's still a very difficult discussion that I have with my patients when I tell them this disease you have is progressive. We have no treatments to reverse the damage or to even stop it. And the best we can do is slow the progression. There's been significant progress in many clinical trials since, but unfortunately, nothing approved since these trials in 2014. There are a number of trials underway and that are promising. And so we press on. And in the future, I suspect that the management of IPF and ILDs will be similar to many of the other pulmonary diseases we manage, like asthma, COPD, pulmonary hypertension, where you have a multi pronged approach targeting multiple pathways with multiple therapies. And ultimately, I would say stay tuned. I'm sure we'll meet again on another podcast episode when the next FDA-approved treatment comes around.
Yes, definitely. We'll pencil that one in for our next breakthrough therapeutic trial. Awesome. All right. Well, thank you, everybody, for listening. Thank you to Robert and Dr. Ng for joining. That's a wrap for us today on today's episode. I hope you all enjoyed it. Make sure to give us a and follow us on social media and wherever you get your podcasts. It does help people find the show. And we'll be back with you again soon with another episode.